A warm greetings to one and all present here in this virtual platform. Presently, the frontline warriors are fighting against the hidden coronavirus all over the world, and the second wave of COVID-19 is going on in our country. As the virus is hidden and it is repeatedly changing its trend, the war is challenging for all the healthcare personnel and it is very difficult to control the infection. Among those health workers, the nursing personnel are the backbone of this ongoing war. So, COVID-19 is the challenges for nurses. I, Chinmay Chaudhary, tutor, College of Nursing, VIMSAR, Burla, going to introduce you about COVID-19 second wave. And my topic is limited to identification, severity and lab diagnosis of COVID-19 infection, as time is also limited. As we all know, COVID-19 is a highly contagious disease and mainly transmitted person to person through droplet infection. At first, only more than 60 years population were at risk, but now the second wave of COVID-19 is affecting both youths and children rapidly. Majority will be seen in the younger generation. Till date, there is no definitive treatment. Only supportive care is being provided to the COVID-19 positive cases. 10 to 15% of the total positive cases need hospitalization and 5% of total positive cases require intensive care unit admission. And the mortality rate in our Odisha is 0.52% and in our India that is 1.5%. As in the COVID-19 second wave, there is significant need to increase ICU beds for which increased number of manpower is also required, mainly the nursing personnel, because the nursing personnel's role is pivotal. They monitor the patients, then early detection of warning signs, then preventing preventable complications, then even counseling and psychological support is being provided by the nurses to the patient, even their family members. Now we will discuss about how we can define a case, or to whom we will say a confirmed case or a suspect case. Okay, any person who have arrived from a high load area and presence of any symptoms in last 14 days will be called as a suspect case. High load area means where in an area majority of COVID-19 positive cases are found. Okay, then next, any person having contact with a laboratory confirmed case and having symptoms will be said as suspect case, or any healthcare personnel having symptoms of COVID-19, or any hospitalized patient having symptoms of severe acute respiratory illness, that is SARI, the symptoms like fever and cough and or shortness of breathing. Then any person having direct and high risk contacts without any symptoms or asymptomatic direct and high risk contacts are also suspect cases. Okay, these five statements will define a suspect case. The next, to whom we will say confirmed case, the person with laboratory confirmation of COVID-19 infection irrespective of any clinical signs and symptoms will be said as a confirmed case. Then we will discuss about the mode of transmission. There are various mode of transmission and the first mode is the droplet transmission. It is transmitted human to human via sneezing, coughing, talking. Then next, aerosol generating. Aerosol is formed during the procedures like suctioning, then intubation or any surgical or dental procedures. Then gastrointestinal secretions like in feces, saliva, anal secretions. Then in fomites, contaminated surfaces like mobile phones, furnitures, utensils, clothing, etc. And in sexually transmitted, as virus is present in semen and other body fluids like blood, urine, tears, and it can also transmit from mother to child during interpartum period. And these three sexually transmitted other body fluids and mother and child, these are having low prevalence of transmission, to whom we will say as high risk population or high risk group. The age more than 60 years are high risk, or the comorbid diseases like cardiovascular, diabetes mellitus, hypertension, chronic lung, kidney or liver disease, or CBA, or any immunocompromised states like HIV/AIDS patients or organ transplanted patients or cancer patients, or obesity. Obesity is also high risk group because obesity worsens outcomes from COVID-19. People who are overweight may triple the risk of hospitalization due to COVID-19 infection. Obesity decreases lung capacity and make ventilation more difficult for the person. Then happy hypoxia. Youngsters may have happy hypoxia. Happy hypoxia means there will be no breathlessness, there will be no symptoms of breathlessness or any other symptoms till the oxygen saturation level decreases to 80%. Okay, after decreasing the 80%, the patient will have severe illness with COVID-19. So he or she needs the ICU setup admission. Okay, then next, anyone can get sick with COVID-19 and become seriously ill or die at any age. Then next we will discuss about the common symptoms seen in COVID-19 infection. The four most common symptoms are fever, sore throat, dry cough, myalgia, dyspnea, and in this less common symptoms are seen as loss of taste or smell, nasal congestion, conjunctivitis, headache, muscle or joint pain, skin rash, nausea or vomiting, diarrhea, chills or dizziness. And in severe COVID-19 disease, the symptoms are shortness of breath, hypoxia, loss of appetite, confusion, persistent pain or pressure in the chest, high temperature that is more than 38 degrees Celsius. And in less common symptoms of severe disease, we will find irritability, confusion, reduced consciousness, there may be or may not be seizure, anxiety, depression, sleep disorders, strokes, encephalitis or nerve damage. Now we will discuss about the clinical severity of COVID-19. How we can distinguish a patient with COVID-19 infection, that the patient is having mild illness or moderate illness or severe illness. First we will discuss the mild illness, that is uncomplicated illness. In this, patient may features with non-specific symptoms such as fever, cough, sore throat, nasal congestion, malaise, headache, and without shortness of breathing or hypoxia. And the elderly and immunosuppressed may present with atypical symptoms. And this type of patients doesn't require hospitalization. Next, in moderate illness or mild pneumonia, patient will have pneumonia, but there will be no signs of severe pneumonia, and the respiratory rate will be more than equal to 24 breaths per minute, and patient have breathlessness, and the oxygen saturation level will be 90% to 93% on room air. And in children with non-severe pneumonia has cough or difficulty in breathing or fast breathing. Fast breathing can be defined in less than 2 months of child is respiration rate will be more than equal to 16 breaths per minute, and in 2 to 11 months respiration rate will be more than equal to 15 breaths per minute, and in 1 to 5 years of children we will find the respiration rate more than equal to 40 breaths per minute. Then next, in severe COVID-19 illness, we will find several diseases or complications that are severe pneumonia, then acute respiratory distress syndrome, that is ARDS, then sepsis, multi-organ dysfunction syndrome, MODS, then septic shock, then multi-system inflammatory syndrome in children, MISC. We will discuss one by one. First, In severe pneumonia, the adolescent or adult patient may present the features like fever or suspected respiratory infection plus one of the following, that is respiratory rate more than 30 breaths per minute or severe respiratory distress or SpO2 level decreases 90% on room air. And in children we will find cough or shortness of breathing plus one of the following, that is central cyanosis or SpO2 level decreases to 90% on room air or severe respiratory distress, for example grunting, chest indrawing, or inability to breastfeed or drink, lethargy or unconsciousness or convulsions or fast breathing. In acute respiratory distress syndrome, the onset of the patient will be new or worsening respiratory symptoms within 1 week of known clinical manifestation. And in chest imaging, we will find bilateral opacities not fully explained by effusion or lobar or lung collapse or any nodules. Then the origin of edema will be respiratory failure not fully explained by cardiac failure or fluid overload. Then sepsis. In adults, it is life-threatening organ dysfunction and clinical manifestation will be altered mental status, difficulty or fast breathing, then low oxygen saturation, reduced urine output, fast heart rate, weak pulse, cold extremities or low blood pressure. Then skin molting or laboratory evidence of coagulopathy, thrombocytopenia, acidosis, high lactate level or hyperbilirubinemia, and there will be low WBC count. And in children we will find suspected or proven infection and there will be more than or equal to 2 systematic inflammatory response syndrome, that is SIRS criteria, of which one must be abnormal temperature or white blood cell count. Then next, in multi-organ dysfunction syndrome or MODS, it is the development of potentially reversible physiologic abnormalities involving 2 or more organ systems, and it is life-threatening physiologic clinical features and it requires ICU. And it affects the organs like lung, kidney, heart, cardiovascular system, GI system, hepatic, neurologic, hematologic, immunologic or endocrine systems. Then in septic shock, the adults may have persisting hypotension despite of volume resuscitation and vasopressure to maintain MAP, mean arterial pressure, more than equal to 65 mm of Hg, and serum lactate level should be less than 2 micromole per liter. And in children, hypotension or 2 to 3 of the following: altered mental state, bradycardia or tachycardia, prolonged capillary refill, that is more than 2 seconds, or warm vasodilation with bonding pulses, tachypnea, molted skin or petechial or purpuric rash, increased lactate or oliguria, hyperthermia or hypothermia. Then multi-system inflammatory syndrome in children, MISC. The clinical features may be fever that lasts 24 hours or longer, vomiting, diarrhea, pain in the stomach, skin rash, feeling unusual tired, fast breathing, red eyes, redness and swelling of lips and tongues, hands and feet, then headache, dizziness or lightheadedness, and enlarged lymph nodes also. And the emergency warning signs will be severe stomach pain, difficulty in breathing, pale gray or blue color skins, lips or nail beds depending on skin tone. Then there will be new confusions, inability to wake up or stay awake. And it is very important for the nursing personnel to early detection of this emergency warning signs for recovery of the patient. Then we will discuss about the laboratory diagnosis of COVID-19 infection or coronavirus. the preferred sampling is done through throat swab or nasal swab, and in alternate nasopharyngeal swab or bronchoalveolar lavage or endotracheal aspirate is done. After the collection of the sample is to be mixed with the viral transport medium and transported through cold chain for the laboratory testing, that is for RT-PCR or rapid antigen test. In this picture, you can see sample vials and virus transport medium. After collection of the sample, it is mixed with this VTM and then wrapped with the cotton or tissue paper. Then after wrapping, paraffin is used to cover or sealing this. Then it is sealed with sellotape. Then it is kept in the 50 ml centrifuge tube or any plastic container or ziplock pouch or cryo box. After that, it is kept in the outer container with hard frozen gel packs. Then it is sent to the laboratory for further testing with proper leveling of the sample. So, what are the general guidelines for sampling? Sampling should be done by trained professionals using proper PPE with latex-free purple nitrile gloves while collecting the sample from the patient. And infection prevention control should be maintained strictly, and there should not be entry to visitors or attendants to prevent cross infections. Then after collection of the swab, it should be labeled and triple layer packed, and it should be spill proof transportation, and online requisition through sample referral form and creation of sample referral ID of each specimen. Then after the procedure, proper disposal of all waste generated. Now we will discuss about the respiratory specimen collection methods. First, in lower respiratory tract, through bronchoalveolar lavage or tracheal aspirate, we can collect the sputum. Collect 2 to 3 ml into a sterile leak-proof screw cap sputum collection cup or sterile dry container. Then after, it should be sent to the laboratory with proper procedure. Then in upper respiratory tract, there are two methods, that is nasopharyngeal swab method and another is your oropharyngeal swab method. In nasopharyngeal swab, tilt patient's head back 70°, then insert flexible swab through the nares parallel to the palate until resistance is encountered or the distance is equivalent to that from the ear to nostril of the patient. Gently rub and roll the swab. Leave the swab in place for several seconds to absorb secretion before removing. Okay. And in oropharyngeal swab, tilt patient back 70°, then rub the swab over both tonsillar pillars and posterior oropharynx. Avoid touching tongue, teeth, gum. Okay. Then only synthetic fiber swab with plastic shaft, and it should be placed the swab immediately into VTM, that is 2 to 3 ml of VTM. Okay. The chest X-ray has also major role in the diagnosis of COVID-19. In this chest X-ray, we can find consolidation, then reticular interstitial thickening, then ground glass opacities. And chest X-ray has little diagnostic values. Then CT scan. CT scan is not routinely advised, and it should be avoided in children also because it is a high risk of exposure, radiation exposure, and in later stage it may have cancer. Okay, in CT scan you can find bilateral ground glass opacities. Bilateral ground glass opacities. Here you can find this is bilateral ground glass opacities, GGO. Okay. In next, You can also find crazy paving. Crazy paving are the thickened intralobular and intralobular lines in combination with a ground glass pattern. Okay. Then we will discuss about the frequency of testing. A single RT-PCR, TrueNet, CBNet or RAT positive test is to be considered confirmatory without any repeat testing. Means if antigen test is positive, then there is no need of doing RT-PCR. Then next, no retesting is recommended prior to discharge from a COVID-19 facility after clinical recovery, including for transfer from a COVID area or facility to non-COVID area or facility. Means there is no need to repeat a test before to discharge of a patient. Then, if symptoms develop following a negative rapid antigen test, a repeat rapid antigen test or RT-PCR should be done. Okay. Then, HRCT should be avoided as much as possible as risks of cancer increases in later life due to exposure. As we know, in this war-like situation with overloaded work and stress, being a nurse means to hold all your own tears and start drawing smiles on people's face. Thank you all of you.